Kindly share with us interesting cases or experience of gout patients, the complications and how they are managed.
So I don't want to say it's as interesting cases.
Okay.
Rather, I would like to say it as sad cases or unfortunate cases. Because one of the cases that I've seen a few years ago is a 54 years old Chinese old lady. Because she has menopause, so her uric level is a little bit high. And once she has a gout attack, and then she was given allopurinol by the general practitioner. But then after a few weeks, the patient start to develop skin rash. But she didn't really notice the importance of skin rash in her body. And then further, a few days later, she started to have fever, and then was very unwell, and was admitted to the emergency department and then directly to the hospital because of generalized skin eruption, and also some very severe redness over 90% of her body. So this is diagnosed. She was diagnosed to have allopurinol hypersensitivity syndrome. And apart from the skin problems, she also suffered from renal impairment and also high white cell count. So that patient, we have to manage her as a case of very severe burns in the burns unit, and then with a lot of rehydration, infection control, and then also other nursing care. And she was very lucky afterwards, because after around a month, she can be discharged from the hospital without much sequelae. But then she was really afraid of trying a urate lowering agent again. And after a few months, her gout attack recurred, and then we have to discuss for quite a long time with her about the use of another urate lowering agent, ifegoxostat. But her relatives and she was really worried about having similar episode of hypersensitivity syndrome again. So we tried to check her HLA sequence, and then was found that she was HLA-B5801 fairly positive. So then we can then afterwards we try to explain to her that probably this is the reason for the allopurinol hypersensitivity syndrome, and then she finally agrees to start on ifegoxostat. And afterwards, her gout arthritis, actually her urate level improves very significantly, with no more gout attack, and then no more skin rash. So this is one of the sad cases of seeing patients with allopurinol hypersensitivity syndrome, and you will never forget this type of syndrome, because it is really alarming, and then it's really horrifying to the patients and the relatives. So our second case is more problematic. This is 40-something years old Chinese gentleman. He has a number of comorbidities, including high blood pressure, including renal impairment, and also he is obese, and his BMI is around 30-40 something, around 35. Okay, so of course with this high body weight, she has a little bit of diabetes as well. So his main problem is he has recurrent attack of gout arthritis, but then he really didn't care, because he has too many problems to deal with. So he has to deal with his high blood pressure, he has to deal with the diabetes, and also he has to deal with the renal impairment. And then until when he had a lot of tophi, and then a lot of deformities, and the gout attack recurs very frequently, around once attack every 1 to 2 weeks. then he started to aware of this problem. So he started to come to see me, and then because this was quite a few years ago when Fibrosustat was not really commonly used in our locality. We start him on allopurinol with a very low dose, around 50 milligrams because of the renal impairment a day. But then there was a very mild skin rash developing again. So this time, because of the previous experience, previous experience with allopurinol hypersensitivity syndrome from quite a few occasions, we really, before the start of allopurinol, we really warn the patients whenever there was any skin rash, he has to stop the allopurinol and then come back to see us. So this time, the patients did not develop into allopurinol hypersensitivity syndrome. Instead, he stopped the allopurinol and then come to see us. So when at that time, Fibrosustat was not available in our locality, so we try to think of other methods to control his urate level. So we had think about probenecid. But then, if you remember, the patient has some renal impairment, so the probenecid actually was not really effective. And we tried to use benzbromoron, but then it was also not available in the company in the market. So we have to ask the patients to purchase this from outside, from Europe, and then start on the benzbromoron. However, the urate lowering effect of benzbromoron was not really very good. So we are nowhere. So and the patients continue to have this recurrent gouty attack. So much so that because he has also renal impairment, we couldn't use non-steroidal anti-inflammatory drugs for his acute attack. And also, even for colchicine, it is quite toxic in patients with renal impairment. So we have to give him steroid. And then whenever we give him like 50 milligrams a day of prednisolone, his diabetes was out of control again. So this is very difficult. So finally, we try to desensitize the allopurinol for this gentleman. We start him on allopurinol 1 milligram, not 100 milligram. Okay, the 1/100th of the usual starting dose. So we start him on 1 milligram per day for 3 days, and then we admitted patients to see if there's any skin rash developing. And afterwards, if there's no skin rash developing, then we step up to 2 milligram, and then we step up to 5 milligram a day, and then we step up to 10 milligram, and then 20 milligram stepwise. So this is the usual desensitization program. Because of the possibility of allergy, so we have to keep the patient in hospital, and then we have to observe whether there's any allergic reactions from developing whenever we switch the dose to a higher level. So the whole program actually lasts around 30 days. Until the patients can tolerate 100 milligrams of allopurinol, it was already 1 month stay in the hospital. So we ask the patients, we discharge the patient and ask the patient to continue with the allopurinol 100 milligrams, hoping that the urate level will go down afterwards. Unfortunately, a few months later, she was coached by his family doctor, telling him to stop taking allopurinol because of the previous labeling of allopurinol allergy. So we have to discuss with the patient whether to restart the allopurinol sensitization again, put the desensitization program again. So the patients finally refuse, and then has to rely on the long-term steroid for the control of the gouty arthritis. Until Fibrosustat was available, then we prescribed him with Fibrosustat, and then the gouty arthritis and the hyperuricemia was relatively under control. Not really down to target, but then is relatively optimal, and the patients has a marked reduction on the recurrent gouty attack. So this is another problems with the previous urate lowering agent. So actually, fibrosation has been doing a very good job on these two patients.